Now, medical therapy is usually one of the first lines of defense that we have. Again, there's the antibiotics. If there's allergies, then sometimes what we do is we'll give you antihistamines. Sometimes there's topical nasal steroid sprays. Now there's topical antihistamines that we have in our armamentarium. But also there's prevention. Okay, so if you know that there's something you're allergic to and you can avoid it, that's one thing you should consider doing, because it's very important. If you can avoid it, you don't need the medicines. Now the other thing is if you can't avoid it, well, what can you do to minimize the problem? Well, if you're around a lot of dust or around a lot of pollens, what you can do, and it's over the counter, is you can use a nasal saline irrigation. That helps to wash it away. The longer you leave it in your nasal cavity, the more it causes an inflammatory process, and the more likely you are going to take a acute problem and develop into a subchronic problem, which turns into a chronic problem. So again, I think that's something you need to take a look at. Now again, there's over 20% of the patients that don't respond to medication. So what happens if you fall into that category? Are there other opportunities to improve the patient's outcomes? What can we do? Okay. Well, of course, we're just going to have an overview here. There's 37 million patients with sinusitis in the United States. 8 billion, that's 8 billion in direct costs with regards to the sinus problems. Now, of those 37 million patients, there are actually 7 million that have chronic rhinosinusitis. Now, again, we talked about treatments with medication. It's effective for 80%. Okay? That's important. But what happens if it doesn't work? Well, there's about 1.4 million patients that actually will go to see a surgeon about possible surgical options. And there's many different ones, and we'll brush up on some of them. We won't go into all the details about the different types of surgical options for the patients. But when they get there, there's 900,000 of this 1.4 million that actually say, no thank you. I think that the risk is too great. I will tell you, I have trained and I have done sinus surgery for quite some time. And I can tell you that one thing that's really nice is as times progress, the technology is improving and the rates of complications are lessening. We're improving what we do. And it used to be, when I started training, that more was better. Now we're finding that it's more like the targeted smart missile. You want to go to the focused area. You want to do the least amount of damage possible to effectively create what you need to make that sinus functional. Okay. And I want to use that word, functional. So if they decline the surgery, then what happens is, again, that model that I gave you, the pool that has a broken filter, has a broken pump, it's not able to work, so the antibiotics are over, and the chlorine, if you will, is gone. It's not killing any more of the algae, and you have this sinus infection, and so you have this chronic repetitive cycle. Okay. The other thing I would like to mention is, a lot of people don't know this, but I'm sure that there may be some in this room that may. Before the invention of penicillin, ear disease and sinus disease was the #1 killer. People died from the complications of ear infections and sinus infections. Now, people still do die from complications of ear infections and sinus infections. However, we have better modalities, more bullets and antibiotics to kill, and we still have to do surgery from time to time. So, again, we have to understand that we do have organisms that are becoming more and more resistant to the antibiotics. So if you're on a long-term, continued, repeated cycle of antibiotics and antibiotics, you are selecting for resistant organisms. And then you'll have to go to another class of antibiotics. And then what happens when that class doesn't work anymore? You have a superorganism. Now, there's the term conventional sinus surgery. Well, conventional means conventional for the time. And there's different surgeons that will stay with one method, and it works well in their hands, and there's nothing wrong with that. Every surgeon has to do what works well in their hands. However, what we also need to do is we need to take a look at what's in our patient's best interest, and we have to try and find out what is the next level of technology that's the least invasive, restores the function, and brings people back to their life in a quicker and faster way. And so in conventional sinus surgery, we're trying to unblock the blocked sinuses. So we're trying to restore the drainage and the function. We now, back in the 80s, Messinger and Staumberger, German endoscopic sinus surgeons, went from the radical Caldwell-Luck type of procedures where we used to go underneath the lip, make an incision, open up the maxillary sinus, remove all of the mucosa because we thought it was diseased. That would have to grow back, and that takes time. And we would get rid of some of the pain and the functions, but we had other issues. And so we started to realize that, well, we don't need to remove everything. It's not completely gone. It was thought that the disease was not retrievable. There was too many changes. So Messinger and Staumberger, they came in with the endoscopic sinus equipment, and we restored the function. So now that's what we're going to be using as the term for conventional surgery. But it works by also removing bone and tissue. As you remove the bone and tissue, there's little inflammatory processes that occur because the bone is not covered by the mucosa. You have the mucus that dries and crusts in that area, and it can cause more blockage. So when I used to do, and I still do this because there's appropriate times that you have to use this type of technique. When you do this, the crusting forms and it can block the sinus opening. So the patients would have to come back for what we call debridements, which is basically cleaning out the crust so that the mucosa can grow overlying the bone, and that bone is no longer exposed so it can heal properly. So again, what that can lead to is a lot of pain, the scarring, and the bleeding. This is just some of the instrumentation that was used in what we call now the conventional instrumentation for conventional endoscopic sinus surgery. You have, as you can see here, a lot of forceps. You can see probes. Some of these are used still in balloon sinuplasty. We actually have here the endoscopes. This is what we're going to use to see. These are the things that actually Staumberger and Messinger used to be able to perform elegant endoscopic sinus surgery in the past. So again, what we want to do is we want to use a minimal invasive technique for people. And now we have the ability to take the technology that's used for opening up your coronary arteries with a balloon, which is very gentle. Imagine you have to have something that's pretty gentle. If you're going to thread it through the artery in your vein, thread it up through into your heart, thread it up into one of the coronary arteries in your heart, and then expand it, it better be fairly atraumatic. Otherwise, most people would not really go for it. And we know that we have saved a lot of people from having open heart surgery because of the balloons. And it's the same type of technology that we're actually using in the sinuses. Again, it uses a small, flexible balloon catheter. And again, it gently opens without destroying the bone. The mucosa is still overlying the bone, so you have the rapid healing. And patients do very well. And if it's just the balloon sinuplasty, you can do so well that you can actually go to work within the next day or two. I had a patient about 3 weeks ago that had lung cancer and was not a good candidate for general anesthesia. And he also had hepatitis, and so he was quite ill. And I explained to him that we have these options, we can do this, but he didn't want to go to the operating room. And so he was actually willing to have this done in an office setting. So even with local, topical, in the office anesthesia, I was able to gently open this up. And he did extremely well, and he was driving, and the next day he went back to work. So again, this is a minimally invasive technique that does work. And there's a lot of research behind this that does show that it's safe and effective. And it's even more safe and effective than the conventional surgery that we've done with the endoscopic sinus techniques, as the German famous endoscopic surgeons had purported.